Reciprocal changes are an important concept whenever you're identifying a myocardial infarction. So mirror image J points, ST segments, and T wave changes are seen on the EKG and during ACS. Acute coronary, it's been too long. The presence of reciprocal changes is evident of acute myocardial infarction, or AMI, but absence is not diagnostic. So could still be there even if it's not there. So these are all the reciprocating changes if our facing leads, 2, 3, AVF. Let's go over those. So lead 1, lead 2, lead 3. So lead 3 and AVF down and lead 2. Lead 3, lead 2, AVF. The reciprocating leads of 2 is going to be 1 because 2 is going the opposite direction, as well as AVL because AVL is to the left this way, AVF is going down. So AVF, AVL. Lead 1, lead 2. Yeah, so it's pointing that way, and then the reciprocating is pointing that way. Whenever you equalize and find the mean value of which direction this electricity is going, kind of confusing. And then that's how we're going to determine whether it is our right coronary artery or our circumflex, which artery something is going on in. Most likely, extra electrical activity means myocardial infarction, or along the lines of that. So if it's septum, we got V1, so V1, V2. The opposite of those, we're not doing a 18 lead. Yeah, 18 lead on the back, so we're not going to have any. Left anterior descending. So left anterior on the front, descending is going down. V3 and V4, also none, same, left anterior descending. 1, AVL, V5, and V6. Okay, so these are going to be on the lateral side, right here, V5 and V6. And then lead 1 is going that way towards V5 and V6. And what else? AVL to the left. Yep, everything is pointing this direction, which means whatever that reciprocating lead is going to be on this direction, which would be 2, 3, and AVF. So straight down. Lead 2 is going straight down. 3 is actually pointing, 3 is pointing in that direction of V5. And that's going to be circumflex. So that's kind of why you have so many leads involved, because it is around the heart. It's going to be multiple directions, multiple leads giving off. V4R. What is R? Right ventricle? V4. So V4 right here, mid-axillary. None. Right coronary artery or circumflex is involved. V7, V9. So now we are looking at the 18 lead. We're going past lead 6. The furthest we go, we're detaching these and we're moving it to V7 through V9, which means that something's happening on the rear of the heart, which would be right coronary artery or circumflex because it's still going around the heart. And then the opposite of that would V1 and V2 is on the opposite side of V7 and V9. Yep, right coronary artery, circumflex, left anterior descending. 2. There we go. These figures show inferior infarction and anteroseptal infarction. So we'll do this one first. This is inferior infarction, which means it's going to be lower. What's going to be involved? AVF and what is inferior? SALI, S-A-L-I, V5, V6. That's L, lateral. V5 and V6 is lateral. So I, inferior, is going to be 3. We'll see here. So 3, yep. We have some ST elevation on 3, as well as AVF, because it's happening inferior down. So 3 and AVF, is that 3 or 2? That's 3, yeah, 1, 2, 3. And then what else is going down? Lead 2, lead 3, lead 2 is going down too. So that makes sense. And nothing else is really going, no electricity is going down. Like that's lateral, V4 is lateral. All of these are laterally going across the chest. Same as 1 and 2, these are above these, so you're not gonna see anything there, just using elimination and kind of going backwards. V3, we see a little bit. Now why do we see it in V3? Because V3 is right where it is most likely happening, the epicenter. So not V4, but V3. This might be easier if I lower this. I just want to be able to catch the slides. So 3 is going to be right at the point, probably closest to the infarction that's happening. Okay, that made sense. Anteroseptal infarction. So this is a combination. So we have the septal and we have the anterior. We know it's in the front, and we know that it is septal, which is also the front, but it's like almost like the dead center of the heart. So what's going to be involved for these without even looking at it? Anterior, we're going to have 2, possibly, yeah, most likely 2, 3, 4, 5, probably not 6. Anteroseptal and AVF and 2. So let's look at those. All right, so yeah, 1, wasn't expecting it. 2, you have a little bit there, but not a lot. You should have more in 3, which you can see that we have, along with a little hump. AVF, yep, we definitely have it in AVF. AVL as well. AVR, we have not a lot because it's going the other direction. So it's going the direction of AVL, but even more pronounced in AVF. So we should have it in, yeah, 1, 2, 3. And then, I'm looking, this isn't even the right one. Okay, so 1, 2, we have some depression, some ST depression. And then 3, we also, yeah, 3, we have depression. 2, depression the whole way. AVF depression, AVL looks even, AVR. All right, so we have V1, like I said, antero, so we have that elevation. We have V2, more pronounced elevation. That's probably right where we should see it. Same as V3. V4, we got some too. V5 wasn't, I know V6 we weren't expecting it. Potentially we could have had it in V5 and it kind of dies down in V4. So we're in this is all the center of the heart. But what I'm confused about is AVF. So anteroseptal, so inferior is down. I thought septal was down. Maybe inferior is the middle. Septal. Sally, V1, 2. Well, V1 and 2, yeah, V1 and 2 should have it because of Sally. V1 and V2. 3 and 4, if they're catching it as well, that's anterior. So because it bleeds from, I'm thinking about this all wrong, because V1 and V2 also bleed into V3 and V4, as far as we're looking at the ST elevation here, the ST elevation, because it's also happening here. If it was just this, V1 and V2, then it would be septal. And if it was just V3 and V4, it would be anterior. But because it's both, and it goes from here to here, like if it was just V2 to V3 and V1 wasn't even involved, which you'd still see something, that would be anteroseptal because it connects from 2 to 3. V1 and V2 are a group, V3 and V4 are a group. Whenever you connect those groups, anteroseptal. All right, lateral infarction and inferior right ventricular infarction. Lateral, so it should be wide. Sally, V5, V6, we're gonna see it. And right ventricular, so we're gonna see it all around. If that's the case, we should see it in V2. We should see it in all the V's. And possibly possibly 2. Let's see. Shows lateral infarction. So top is lateral. All right, so yeah, 1, I'm surprised 2 doesn't have it. For some reason 1 has it, so I'm wrong in that aspect. This is the same one, right? Did we just do this? Reproduction 12 lead. I think, yeah, this is the right one. Okay, these are the right ones. All right, so V1, nothing pronounced. V5 and V6, so definitely lateral here. So this is the left side of the heart, anatomically. And then AVL, AVF, left side, we have it in 1. Lead 1, lead 2. I'm surprised it's only in 1. Well, it's also in AVL, looks like. Yeah. Yeah, we got it in AVL. So AVL and 1 are on the same side, the right side. That's why the right ventricle is showing. But these are 2 separate. Okay, yeah, these are 2 separate. Just gonna redo this.